I'd like to welcome Leanne Moskowitz with Iowa Medicaid Enterprise and Luna Bakam with Department of Human Services Targeted Case Management Unit. We're going to start with Leanne today, who's going to talk about person-centered planning for Medicaid-funded home and community-based services and employment service. So welcome, Leanne, and thank you so much for coming today.
Great. Thank you very much for having me. As always, it's always a pleasure. So we're talking about person-centered planning today, and the reason why we're talking about this is that the Affordable Care Act required states to develop rules and regulations to ensure that states develop community-based long-term services and supports in order to allocate resources and provide the necessary support and coordination in order to be responsive to the person-centered needs and choices of older adults and people with disabilities. And the person-centered planning regulations, of course, came out with the same set of regulations addressing the HCBS settings. The person-centered planning regulations became effective March 17th, 2014. And so a complete and inclusive person-centered planning process addresses a person's array of home and community-based service needs in the context of their personal goals, their preferences, community and family supports that they may have, their financial resources, their health care concerns, safety, as well as other areas that may be important to the member or their guardian or loved ones. One of the functions of the person-centered planning process is to help the person and their team to develop innovative and non-traditional ways to meet the member's identified priority goals. And so this is a process that's directed by the member who is needing HCBS support, and the member is encouraged and assisted with directing the planning process rather than taking a passive role in this process. The team approaches the person-centered planning from the member's strengths and what the member has identified as what is important to them. The role of the case manager or service worker or the care coordinator would be to assist the member to identify those things that are important to them, as well as the services and support that are available to meet those identified goals and needs during that planning process, so that information can be put into the person-centered service plan. So with that, let's talk about the plan. So the plan, all Medicaid members receiving home and community-based services must have a comprehensive person-centered service plan. Some provider types may refer to this as a treatment plan. We tend to use those two terms interchangeably with HCBS because when we talk about HCBS, we are also talking about the individuals who participate in the state plan HCBS habilitation program. And those folks tend to receive the services and support through mental health service providers who tend to have treatment plans for their service model rather than a standard disability service plan as we all tend to think of. So anyway, we use those terms interchangeably, so don't let it confuse you if I use both. So the case manager or the care coordinator is responsible to facilitate the member's interdisciplinary team. That means identifying a time and place that's convenient to the member to hold the team meeting, and then assist the member by inviting those people that are important to the member to be there, as well as working with providers to have them present at the table too if providers have been identified for services going forward. The IDT, in conjunction with the member, looks at the member's need for services, develops a comprehensive service plan and treatment plan, again, identifying the member's goals and services and supports that would be important to the member and their goals. The case manager or the care coordinator will monitor the service plan implementation and service delivery, ensuring that the member are receiving the services identified in their comprehensive service plan and that those services are achieving the desired outcomes. We also monitor the comprehensive service plan in a number of other ways through the HCBS quality assurance activities. So there's the provider self-assessment that is completed by targeted providers of specific HCBS services. Those provider self-assessments have specific section identifying person-centered planning, where it identifies the member's participation in IDT meetings, the member's file containing a copy of that person-centered plan, the provider's plan is consistent with the case manager's person-centered service plan. And we'll get into that in a minute, but yes, each provider of HCBS service should have a service-specific person-centered service plan for the members that they're serving under HCBS and Medicaid-funded services. The provider service plan would include the interventions and supports needed to assist the member with meeting their goals, as well as those short-term and long-term objectives and steps to achieving those goals. The provider's plan would reflect the member's specific outcomes. So what is the outcome of the service that's being delivered? And then documentation of any rights restrictions that may be due to a member being at risk, and what the plan is for restoring those rights, and then what the informed consent is around any rights restrictions for folks. So again, some specific requirements that are reflected in that provider self-assessment. And then the HCBS quality assurance staff, of course, looks at those provider self-assessments, and then they go out and do follow-throughs on-site reviews that may be targeted, periodic, or as a result of an investigation or complaint or something of that nature. We also have the individual participant experience survey that also measures whether or not the member is receiving their services as identified in the comprehensive service plan, and whether or not those services and supports are meeting that member's needs. The managed care organizations may also have some additional quality assurance measures that they're also evaluating with their provider networks when it comes to person-centered planning, as well as their community-based case managers and the health homes that they're responsible for. So HCBS services and supports, let's talk about the process. So it starts with the foundation, and the foundation of HCBS is that comprehensive functional assessment, which assesses the individual's need for HCBS services. So most of you know that the state has promulgated rules to adopt the inter-array assessment tool for all of the waivers, with the exception of the intellectual disability waiver, which is utilizing the supports intensity scale. These are core standardized assessments that are intended to be used universally across the population and were chosen for the validity and reliability of those tools. So those are the comprehensive functional assessments that are going to be utilized going forward across the waivers when those rules are finalized. In the interim, we're using the inter-array and the targeted case management comprehensive assessment. Children under the age of 4 for ID population, and children under the age of 3 for the other waiver populations will continue to use the targeted case management comprehensive assessment, because the inter-array isn't rated for children under the age of 3, and then this for children under the age of 4. So just a little FYI that you probably didn't want to know. Anyway, so the IDT team develops the individual service plan and integrated treatment plan, and the individual service plan defines the services and supports that the members will receive. So again, these are the members' identified goals, and then what are the short-term, long-term objectives to meet those goals, service and activities that will help elicit that outcome for those member goals and identified needs. And then those, of course, would be reflected in those provider-specific service plans. So if I'm a provider and I'm delivering pre-vocational services to a member, I'm going to have a person-centered service plan specific to the pre-vocational services that my agency is delivering to the member, which is reflective of that long-term goal, short-term objectives, in order to meet what my pre-vocational goal is, which is, hopefully integrated employment in the community at a wage at or above the prevailing wage for that job or above the minimum wage. So for the person-centered, putting the person-centered planning in context of HCBS, again, as I said, the person-centered plan is the foundation. That person-centered plan identifies the individual preferences. It identifies natural and paid supports. So it is what natural supports are available that the member can leverage in order to have their needs met. It also should provide for flexibility for scheduling of the meeting and then the member's needs and those services. So the services and the paid and natural supports should revolve around the member's needs and their identified preferences. When we think about employment, we think, oh, well, everybody has to have a job from 9 to 3 because that's when the employment service providers are open. Well, in real life, people work around the clock, and so we really need to look at services and supports that are flexible in scheduling in order to meet those individual member needs. And then we need to look at the use of innovation and supports and technology and what's available in members' communities to assist them in achieving those goals. And so all of those things go into the development of a person-centered plan. So when we look at the person-centered plan, CMS has identified very specific requirements for documentation in the federal rule. And so they've told us that service plan must reflect the individual's strengths and preferences, reflect the clinical and support needs of the member. So when we talk about clinical, we're talking about what are their health care needs, are there any health risks for the member, how are those being addressed, those types of things, medication, any types of treatments or therapies that the member may participate in, those kinds of things. And then support needs of the members, what kind of support do they need? Do they need standby assistance for things? Do they need someone to, physically assess them with, activities of daily living? What is the level of support that a member needs in order to, take care of their needs on a day-to-day basis? Again, observable, measurable goals and desired outcomes, interventions and supports needed to meet those goals, and incremental action steps as appropriate. And Luna, of course, is going to get down in the weeds and talk about what a service plan looks like from the case manager's perspective and what they do to pull all this together for folks. Identify staff, people, businesses, and organizations responsible for carrying out the interventions and supports. And that's really important that it's identified who's responsible in order to deliver these services, because that service plan ties to that provider's authorization to deliver that service. On the fee-for-service side here at Medicaid, a member has to have an authorized service plan in the Individualized Services Information System that clearly identifies the provider who's responsible for delivering the services, the units of service, the rate, and the days of service authorization in order for that provider to be able to submit a claim and receive payment for services for specific days of service. And so, again, that person-centered plan is that foundation, and we all know that folks can't remain eligible if they don't have a current assessment. So again, the assessment feeds into the service plan, feeds into the service authorization, which enables the member to receive services and enables that provider delivering those services to get paid. So again, everybody needs to be identified and informed, and it's so important that those providers receive a copy of that comprehensive service plan. So A, they can develop their service-specific service plan, and B, they have this justification and documentation to support the services they're delivering. So the service plan documentation for a person that's receiving prevocational services or who will be receiving prevocational services, the location where prevocational services are to be delivered at the time of enrollment, if they're already receiving them or where they will be received, the number of hours per day of on-site staff supervision needed by the member. That's important information for a provider who's going to be serving the member to know in order to plan their staffing patterns to support that person so that the member is getting their needs met. The plan for when the member will participate in career exploration activities. Again, the goal of Prevoc is integrated community employment, and folks would, benefit from participation in career exploration activities in order to develop a career plan in order to help them achieve that goal of integrated community employment. So document when the provider or the member feel that they'd like to start participating in career exploration. Again, you remember Prevoc is going to be limited or is now limited to 24 months unless there's other criteria in place for the member to continue beyond those 24 months. So folks have to be cognizant of that when planning that career exploration participation. The status of providing the member with information regarding supported employment and the benefits of work, referral to supported employment services. And that's important because as a case manager or care coordinator facilitating the development of that service plan, it's important to think about what's next. So if we're going through pre-vocational services, have we talked about supported employment? Folks don't have to go through pre-voc before they can go to supported employment. They can immediately start accessing supported employment services, in order to obtain a job and maintain a job. So it doesn't have to be one before the other. They can certainly bypass pre-voc altogether and just go straight into individual supported employment with job development activities going on. So, but again, it's going to be based on each individual's needs, what's right for them, what's available in their community, and what the member's preferences are. So if we are participating in Prevoc services, we know that our outcome is integrated community employment. I'm not going to read this whole long definition to you. It's too many words for one page, and I'll just apologize, but it's important. The words are important. We want members to be in individual employment, in the general workforce, or in self-employment, in a typical setting found in the community where member interacts with individuals without disabilities. They're earning minimum wage or the customary wage for that job with the same level of benefits paid by the employer to people working in the same or similar jobs without disabilities. Again, we want folks to be working out in the community just like you or I with the same opportunities that just like you or I have. So with supported employment, again, the outcome of supported employment services is sustained employment, again, at a setting in a job that meets my personal or career goals. And self-employment is the same, however, it's a little less tangible, but the benchmark would be that the member is earning income that is equal to or exceeds the average income for their chosen business venture within a reasonable period of time. And so, a reasonable period of time, I think, identified by the business community has been 2 years, I believe. Is that for self-employment? Sounds right. Anyway, if anybody knows better, please feel free to correct us. Service plan documentation. So must identify for a person receiving supported employment, where are they working at the time they're enrolled in the service, how many hours of on-site staff supervision are they needed each day by the person, The number of other workers who work with the member and also receive publicly funded employment support through their places of employment. And that's important because if you think about the new group employment service, what we formerly called enclave services, is that the reimbursement is based on the number of members that the person is working with. And so if I'm working in a group of 2 to 4 individuals, the reimbursement is higher, say, if I'm working to the provider for those services and supports, than if I was working in a group of, say, 4 to 8 folks. So that's why it's important that we document how many people I'm working with in my employment setting. That's a piece that would be monitored during a service plan review. And then the status of referral to Iowa Vocational Rehabilitation Services. And Iowa Vocational Rehabilitation Services should be the first and preferred provider of employment supports in the state. That is their expertise. And in our resource sharing agreement with the Iowa Vocational Rehab Services is that targeted at folks age 24 and under. So if a person is age 24 or under, they will first go to IVRS in order to receive those job development discovery type of activities, and then job coaching to stabilization, then come back to the HCBS waiver or the HCBS habilitation program to receive their long-term job coaching services and support through the waiver or HAB. So service plan documentation, again, has to reflect providers of services and supports, including unpaid support provided voluntarily in lieu of the waiver or state plan. We want to know who the name of the provider, the services that are authorized, the units of service that are authorized, and the period of service of authorization. And this should all be reflected in the service plan because that helps us avoid duplicate care when case managers are doing service plan monitoring. We might have some folks that are getting in-home health-related care, consumer-directed attendant care services. They might be getting some services through IVRS, and we want to make sure we're not duplicating that under the waiver, those types of things. So we want to make sure we're documenting, those services that Medicaid pays for, as well as those services that are funded under other publicly funded supports or even unpaid or natural support that the person has access to. We also want to identify risk factors and measures in place to minimize those risks. So if the member has a seizure disorder that perhaps puts them at risk of having a seizure in the workplace or perhaps during transportation to work, what is the safety plan that has been put in place to respond to if the member should have a seizure while at work or being transported to work, and what is the plan to help mitigate those risks? Are there other things that can be done to help minimize the risk? Sometimes yes, sometimes no. It just depends. But those things should be identified. Service plan documentation includes the individuals important in supporting the individual. Again, family, maybe a best friend, maybe a pastor, definitely service providers. Includes the names of individuals responsible for monitoring the plan. So, of course, if a member's with a managed care organization, it's going to identify that managed care organization and who that member's community-based case manager or integrated health home care coordinator is. Same thing on the fee-for-service side. The service plans always identify who that case manager is that's monitoring those plans. Again, the plan has to be written in plain language and understandable to the individual. We tend to use a lot of jargon in our field, and so it's important to try and keep the language plain and understandable by the person, so that they can also be responsible for the implementation of their own plan. We also want everyone to sign the plan because we want the acknowledgement that, what's in the service plan, people are acknowledging that's what they're responsible for. And that, it also basically documents their attestation that, yes, this is my piece of it when they've been identified in the plan. The plan needs to be received by the member. This is their plan. That member should have a copy of their own service plan. And others involved in the plan. If there are providers that are identified in the plan, any HCBS service provider should have a copy of that comprehensive service plan. And it may also, of course, be provided to other people with the member's release and consent. We want to include purchase and control of any self-directed services. That's real important. Member might choose to use the consumer choices option to purchase their employment supports, and so those should be identified, who their employment support provider is through CCO, how many hours a week, what kinds of activities that person's going to do, those types of things. And then we want to make sure that the plan doesn't include anything that's unnecessary or inappropriate. Again, you're all aware of the budget situation here in the state, and we want to be good stewards of the taxpayer dollars. So we want to make sure that we're not authorizing duplicate services. We want to make sure that services are targeted and appropriate objectives are in place to meet the intended outcome of the services that are being provided, and then those progress towards the outcome achievement is actually being monitored. So with that is kind of high level what's involved in person-centered service planning, and you've got some links to online resources. You have our new second edition Iowa Employment's First Guidebook there, so please, that would be your one-stop shop for health and person-centered planning. Again, that's Iowa Employment First Guidebook, and then also on that same page, which is the HCBS Services homepage, you'll find the frequently asked questions around prevocational and employment services. And if you don't find your question answered on that page, then please get with the folks at Iowa Providers and send your questions in, or send your questions in through IC, or I guess you feel free to direct email me too, since you have that information, and we'll get your question answered. And as new questions come in, about every 3 or 4 months, I've been trying to comb through my email and add those new questions to the FAQ. And then, of course, MHDS's employment webpage has a lot of different resources and links for employment providers as well, and case managers for service planning interests. So, and then you got some local contacts, some of our local state employee folks, myself, Lynn Nibling over at MHDS, who is the Employment Policy Specialist for the Mental Health Disability Services Department, and Leanne Russo, the Resource Manager over at VR. She doesn't know, I don't know who does at VR. And then Tammy Ansbaugh with the CDD, and any of these folks can answer questions around employment, in addition to our partners at ICP and IC. So thank you very much. Luna.
Thank you, Leanne. We'll transition right over to Luna Bacam, again with DHS, Targeted Case Management. She's going to share with us a case manager perspective, and again, how she and her unit implement person-centered planning and employment. Luna?
Thank you, Jess and Leanne. Again, my name is Luna Bacam, and I am one of the trainers for the DHS Targeted Case Management Unit, also a member of our unit's employment team. I've had the opportunity to participate in several meetings to discuss changes in employment. That information then gets passed down to our supervisors, our case managers, associates, and other staff in our unit as well. So today, I will be going over how our unit applies and implements person-centered planning with each of our members. I will also discuss how we record these efforts in our documentation. As you know, person-centered planning is crucial in planning for individualizing employment outcomes. Person-centered planning enables individuals the opportunity to increase their personal self-determination, improve their own independence, and be a part of the decision-making process based on accurate information and knowledge. Our case managers are expected to see each member at a minimum of quarterly. However, members are seen based on individual need, which sometimes requires more frequent visits. Progress updates are completed during a face-to-face visit with the member in that member's home. During this time, in-depth conversations take place with the member's legal representative, or staff member. Progress updates include gathering information about the member's physical condition, condition of the home, medical, mental health, safety, employment, and other areas of that member's life. Progress updates are completed and documented in our medical records management system. That's called Segment. Again, our case managers have conversations at least quarterly with each member regarding that member's employment status. Members are asked about their individual desires as it relates to employment, and our case managers discuss the benefits of being competitively employed and answer any questions that members may have about obtaining or maintaining employment. This is a good time for case managers to address any concerns that the member or their family or legal representatives may have about being employed. If there are questions that our case managers cannot answer, they do a very good job of reaching out to members of our employment team for clarification. In addition to our progress updates, case managers also include information regarding employment in our individual care plans, or ICPs. These are also known as Leanne said, comprehensive treatment plans. There may be some changes to the formats of our own personal ICPs that we use right now in the near future. So at this time, we've decided not to make a separate treatment summary for employment. But the case managers are simply adding this information to the existing ICP under maintenance activities or other services. Case managers have been trained to have a discussion with each of their members, document that member's response to the discussion regarding employment, and make referrals as necessary. At the time of the ICP, members are provided with information about the benefits of being employed. If there are any questions regarding employment, case managers are able to answer those questions and concerns. So we were moving on to ICP meetings. Our ICP meetings are very person-centered. The members are asked who they want to lead their meeting, who they want at that meeting, when they want that meeting held, and where they want that meeting held. Members and their legal representatives always have a choice in who they want to provide their services. This is done prior to that ICP meeting. The ICP reflects the person's strengths and preferences. The ICP also reflects the services and supports, and that consists of both paid and unpaid supports that will assist the individual to achieve identified goals, the frequency of services, and the providers of those services and supports, including, again, natural support. Case managers ensure that when we're writing these plans that our interventions are measurable and observable. Again, we clearly identify the provider, the type of service, the frequency of service, and the dates of service. Case managers monitor service implementation and look at outcomes. We also have very frequent contact with each of our providers in order to monitor our members' progress and also to identify any barriers that may exist. As Leanne previously discussed, as far as specific to employment services, we would include information regarding the location of where Prevoc services are being developed or delivered, the plan for when a member will participate in career exploration, and case managers are mindful of time limits, and they are getting that information to our members and their representatives as well. Again, we also document the hours of on-site supervision for those members. As you know, there are special requirements for members who are sub-minimum wage earners. Case managers are to have specific discussions about moving into integrated community employment. These discussions include the value of working, increased independence, and improved overall happiness. Our case managers are expected to fully explore vocational opportunities so the member can make an informed choice about employment. Case managers discuss career counseling, which could include Social Security Administration benefits, benefits planning, soft skills, self-advocacy skills, and also we discuss information and referral, which could also include ticket to work or veteran affairs. Case managers are expected to answer questions regarding employment and to provide clarification to members and their families. Case managers are expected to document their conversations, the member's response to that conversation, and any follow-up activity taken. Ultimately, our member makes that final decision regarding their employment status.
Right. Thank you so much, Luna and Leanne. I think that'll wrap up the presentation for today on the role of person-centered planning and achieving integrated